with the preparation for exam. So without wasting time, I will hand you over to the Secretary of the NSA Education Committee, Dr. Oranusi, for the rest of the, to tell us how the webinar will be run in a nutshell. Thank you very much. Dr. Oranusi, please.
Thank you very much, Prof. Good evening, everybody, and welcome to the 8th webinar series, first session of the 8th webinar series of the Nigerian Society of Anesthetists. This webinar will last about 90 minutes, within which we would have questions coming from our facilitators to our residents who have volunteered to be part of this webinar, and they will be answering questions in preparation to the exam. The facilitators would decide for how long we would have each resident take on his or her question, and after the questions, there may be corrections, or facilitators will have if one or two things to add to what has been said already. Then at the end, we expect to be able to allow questions from the floor. We would advise anybody that has questions or anything to say to either raise hands or type in the chat box. Having said that, I would want to, at this point, invite the moderator for the webinar, Dr. Jonathan Chukwuemeka Eya. He is the former head of department and former head of the ICU former head of Department of Anesthesia and former head of ICU at the Enugu State University Teaching Hospital, Park Lane, Enugu. He's moderator for today. Dr. Eya, you have the floor, please. Thank you.
Thank you, Dr. Rand. Good evening, the professors, my teachers, senior colleagues, ladies and gentlemen. Welcome to the 8th webinar series, first section of the NSA, Nigeria Society of Anesthetists. I will first of all like to use this opportunity to thank the organizers of this project. It is a privilege that has been given to me to moderate this exercise. It is not only that the organizers have organized this, have done this, it has given anesthesia department, a recognition in the global academic map. It has not only given opportunity to the anesthetists and non-anesthetists to increase their knowledge in anesthesia and beyond. It has also served as a link, as a bond, among the anesthesia family. Today is a case-based discussion. And our erudite discussants are Dr. Oyedepo Olariwanju, is an associate professor and consultant anesthetist at the University of Ilori Teaching Hospital, Kwara State, Ilori, Kwara State. And the second is Dr. Hart Plekabo, a consultant anesthetist with the University of Port Harcourt Teaching Hospital, Port Harcourt, River State. Well, as the secretary has pointed out, there is going to be timing in each question, each case that is going to be presented and answer that will be given to it. We are going to allot 10 minutes for each case presentation and then reactions or answers to such case presentations. 10 minutes. The emphasis here is that if a case is presented and somebody is offered opportunity to react to it, the time taken to present that case and all the reactions surrounding that case will not go beyond 10 minutes. This is to give us the opportunity to attend to so many questions within the time limits. And at this point, I wouldn't want to go further because our facilitators may have one or two other things to chip in as I hand over to them. So Dr. Yedepo and Hart Flekebo, over to you.
Good evening, everyone. Thank you. I want to thank the organizer of this webinar for giving me the opportunity to take part as a facilitator in this webinar. It is a good thing that the association, that is Nigerian Society of Anesthetists, have been able to put in place in order to ensure that our residents are well trained and also well versed in the practice of anesthesia. And this will also enable. Hello, can you hear me?
Yes, we can hear you.
Can you hear me?
We can hear you.
This will also enable okay. This will also enable the residents who are going for exam to have a very good results at the end of the day. So this is like a drill before the exam. So without wasting much time, I have been given the opportunity to have the list of participants, and then I will be calling their names. I think I hope all the participants that are on the list are available here. Okay. So, however, I will look at the list and see whether I'll be able to get all the list of the participants here. Dr. Umar Abdullahi Sunusi, is he here? Dr. Abdullahi from AKTH. Okay. What of Dr. Adeoye? Dr. Adeoye. So let me, it's better to look at the list. Okay. I've been calling the list or the names on the list. It's like many of them are not here. What of Dr. Ann, FMC Oweri? Dr. Ann, FMC Oweri.
Hello, good evening, sir. Is it Dr. Anene?
Okay, Anene, sorry. Anene,
yes, I'm
okay.
here, sir. I'm here, sir.
Okay, you are here. Okay, so that's good. You have had that you are going to be given only 10 minutes to discuss the question, and you must be straight to the point. Okay?
Okay, sir.
The question 1, a 5-day-old neonate is for tracheoesophageal repair. Discuss the preoperative management and what are the intraoperative challenges. That's the big question. Okay. A, discuss the preoperative management. B, what are the intraoperative challenges? I think you get the question right.
Yes, sir.
Okay.
Okay. Okay. The work introduction. Tracheoesophageal fistula is one of the congenital anomalies that occur in some neonates. Okay. At times, it's associated with other congenital anomalies. So, in my pre-op visit, I will, while confirming the history, suggesting tracheoesophageal fistula, whereby the mother will be telling me that this person, that the child vomits while being breastfed. Okay. I also need to be on the lookout for other associated congenital anomalies, like whether there's any cardiac anomalies, you know. So I will do a thorough cardiovascular examination. Then I also look at the limbs, whether there is any associated limb abnormalities. Then I also ask around this child, find out whether the child is urinating, well, to find out whether there's any associated renal problems. Then okay, having gotten that, I will. Okay, yes. In the examination, this child, consider that this child will be able to tolerate whatever the child is being breast milk the child is receiving. I need to examine this child. The child is likely going to be dehydrated. Okay, and then possibly it might also be pale. Then there might also be in the respiratory examination, there might also be respiratory infection. So I need to do do a detailed chest examination, being on the lookout for any signs of infection like crackles, fine or cross crackles. Then also be on the lookout for the respiratory. If there is any sign of infection, there might be tachypnea. And then in cardiovascular, I will need to listen.
Doctor, you don't have much time. The question is very straightforward because I don't want you to waste much of the time. The question says, what are the preoperative preparation? So how do you?
Okay, now.
So go straight to the point.
Yes, I will do some investigation to confirm. I'll do some investigations to confirm this pathology. Okay. Do chest X-ray and then echocardiography.
Before you do investigation from OSU, what are the things you want to find out that will be of help in preparing this child?
Okay.
Because before you go to investigation, in your history, you have not given us most of the things that we look for when you have a patient with tracheoesophageal fistula. So you have to be very succinct and direct. You don't have to waste time, okay?
Okay, in my history. Okay, I also want to find out whether there's any family of the sibling that also has this kind of abnormality. Then whether the child has sought any medical care for now. Okay, I also want to find out from the mother her antenatal visit. Was she did she attend the antenatal visit the way she should? And then where did she attend an antenatal visit? Okay. So that's basically all for the history. Then for the investigation, I need to do the full blood count, the hemoglobin to check the hemoglobin concentration of the blood, then WBC to also check whether there's any sign of infection. Then I will do a serum urine creatinine to assess the renal status of this patient. Okay, then we'll also do there's always some radiological investigations like chest X-ray to confirm the pathology, then echocardiography to look at echocardiography, yes, to then I also do echocardiography then. That's basically, okay, that's the one. Okay, then the treatment.
I can hear you, but I think you have taken almost 7 minutes, and it is good.
Okay.
Sorry, I'm coming in at this point.
Okay,
It is good if we give our answers and then allow some of our senior colleagues to come in within that 10 minutes. Everything has to be done within 10 minutes. So if you take the entire 10 minutes answering, it means even correcting you will be difficult. I think we are giving, we're giving him so much time to answer this question based on the 10 minutes timing we are using.
Okay, sir. Well done, Dr. Anene. While you have an idea of this question, you're everywhere, okay? I know putting you on the spot also would disorganize your thoughts. It would be nice when you're asked pre-operative, what you're going to do, just think of yourself in the ward. When you go for your pre-operative assessment, what do? You take a history. You take a history, so you have to go just the normal history taking. Do your history, physical examination, investigation. That's just what they want from you, okay? If you follow that pattern, you'll be able to say a lot rather than move from history of breastfeeding to history of immunization and all that. If you are able to go through your history, physical examination, investigation, you have so many things to say. So try and arrange yourself. You have an idea, but if you arrange yourself, you see that it will flow better. Thank you.
I don't know if there are more contributions. We still have 2 minutes left. 2 minutes, 9 seconds. If there's any contribution to this, it could also be offered.
Yeah, I think you have not, if you have been managing tracheoesophageal fistula, it's not a difficult case. This is a patient who is having fistula between the airway and the GIT. And one of the problems that we have is soilage of the airway, breathing difficulty. You understand? These are challenges. This is a child who cannot feed. So you cannot link it to it. And then what do we do? How do we make the diagnosis? You have this history of vomiting, a lot of salivation, patient have chest infection may be there. Patient may have, because of the aspiration, depending on the location. Then you want to rule out congenital, associated congenital anomaly. So these are things that you look for. Then passage of NG tube. You pass NG tube, the SAU is not going through. So what you do is to preoperatively, one of the preparations is to pass an NG tube and continue to suck continuously so that you prevent soilage of the airway. Okay? Then you give the patient oxygen if the patient is desaturating. If there's congenital anomaly, during your examination, you're going to rule out all those. These are things that you have to be concise. You cannot write everything about it, but these are specific things that you need to know, okay, in your preparation. And if there is any chest infection, you start antibiotics. If there is dehydration, you rehydrate the patient. You take blood samples to check for E and U. The radiological examination, you know. These are things that we have to do. And this patient have to also have IV fluid management, okay? Because the patient cannot take orally any longer. Okay? And there are 2 ways of managing whether the patient has another, you put a gastrostomy before, or you are doing complete repair. Okay? So you've got to be concise and tell us what are the things that you. So the other thing, the second question. So because there are a lot of things, time is against us. We cannot waste so much time.
Yeah,
I'm just telling you that
specific. You can imagine that 10 minutes for this question is gone.
Gone. So with only one aspect of the question. So, and these are specific things. They have made it simple. Direct, what are the preoperative preparation? You have to know that you are going to do investigation, full blood count, and grouping and cross-matching because this is a neonate. Okay, you got to get blood ready. Okay, you got to get prepared for even the postoperative care. Make sure that you have a ventilator because the patient may have been intubated before the procedure and then being ventilated. and when you want to ventilate the patient. Okay, what are the challenges? I don't know whether we have the moderator, whether we can give him the opportunity
But
to.
this is the very first
just talk.
question we are attempting. I think we can give some grace, maybe 2 to 3 more minutes to see to the end of the question. But next question, we are going to be faster than this. Let us just go straight. I advise the candidate to go straight to the point so that we'll be conscious of the time we are allotting.
Okay, yeah. This person is likely to be dehydrated, so fluid therapy is key. So wherever you do strict input-output monitoring, as you are giving you a fluid, you also checking out the urinary.
What is the first thing? What is the first thing? Intraoperative challenges, Abby?
Yes.
The first thing. What is the first challenge? This patient has come on the table. What is the first challenge?
Okay, because the patient is a neonate, there are chances of being a difficult airway because they have their peculiar anatomy. So
what type of induction are you going to give?
Okay,
How do you induce the patient? How do you intubate the patient?
Okay, I will induce with inhalational induction, sir. I will do with inhalational induction, preferably halotene, because halotene is sweet smelling. I will do with halotene. Then the intubation will be carried out by a most experienced anesthetic, considering the pathology we have at hand. Then, while I have my difficult airway standby, then after the induction of the anesthesia, then I participate the tracheal intubation.
Well, if blood is available, we give the blood. Then the patient is prepared for surgery, because surgery and emergency, there's no time to fast this patient. So we're taking the patient to the theater. We're going to do what we call rapid sequence induction for this patient, because it's assumed that this patient is a full stomach. It's an emergency, so there was no time to fast this patient. So the patient presents to you the theater. Before it comes to the theater, we've already checked our machine check, our drugs are drawn and labeled.
Hello. When you are not to manage, when they say consideration, this is an elderly patient with an emergency condition. The patient has typhoid perforation, is likely to be toxic, is likely to be septic. You understand that kind of thing? Patient has not been eating for some time because of the pain. Patient is having abdominal pain. So you say the consideration will be the patient's condition, sepsis, antibiotics has to be started before, isn't it? Patient may be apathetic. You may need to give oxygen. The patient may be desaturating. Okay? Then you may need to do what? Look at the blood pressure. Because of pain and whatever, the blood pressure will surge. You understand that kind of thing? These are things. Then you will also talk about electrolyte imbalance. It's likely to be present in this patient. So I'm going to correct. So it's not that you should be managing and you go on fast. It's going to be rapid sequence induction. The patient can, because by the time you want to intubate the patient might regurgitate. So you have to do rapid sequence. But however, too, you must know that this is a patient with high blood pressure. Won't you give something to control if the blood pressure is high?
Yes, sir. I will give.
These are the things you need to talk.
Yes,
you have to obtain the sympathetic response to laryngoscopy and intubation.
Yes.
You have to monitor input and output because patient is toxic and has to be taken. Electrolyte and fluid imbalance may be present. So these are pain. How do you manage pain? You have to also talk about that. Although that's the second aspect of the question.
Okay, sir. So the second aspect of the question talks about enumeration of the options for post-operative anesthesia. So for the management of pain, we'll do a multimodal approach for this patient. So for post-operative, we can give it's an abdominal surgery. I'm trying to choose the analgesia I'll give for this patient because opioids.
They say enumerate. It means there are so many, not just one. So you can be safe and say you use the WFSA letter, post-operative pain, acute pain. If you say WFSA letter, from there you can decide on what you want to do. Multimodal, yes. But with WFSA letter, you can get a lot of things that you can give. And with that, at least we know that you know what you're talking about.
Thank you, ma. Thank you, ma. Yes, ma. So the WFSA ladder we can start with paracetamol, ibuprofen, but based on the weight for the patient. Then
that's WHO. You're talking about WHO letter. WFSA is from down up. All right. Infiltration, regional blocks. You do your strong opioids, mild opioids, and then opioid-sparing drugs.
Okay, ma. Okay, I'm starting from the lowest to the highest. The infiltration, I thought we can do the infiltration in the theater. Then for this patient, it's an abdominal surgery, so it's a multimodal approach. You can give paracetamol, opioids, but we have to be mindful of the opioids we are giving because opioid can cause post-operative nausea and vomiting. So we should be careful. So we can do our blocks like epidural. Patient will benefit from an epidural anesthesia post-op. Can give him what we call walking epidural. Then
so in a situation where you have only opioids and you can't do away with it, what can you do? Since you're worried about post-operative nausea and vomiting.
Yes, ma. We can do blocks, regional blocks for the patient, ma.
The opioid is the only thing available, and you want to use it. What can you do? You can't throw it away because you're thinking of post-operative nausea and vomiting. You have your antiemetics. That's why they are there.
Okay. Yes.
Dr. Adio, are you hearing?
Yes, ma. Sorry, they're disturbing. Yes, ma.
Gentlemen and ladies, we've spent another 10 minutes on this question.
Yes, ma. Thank you, ma.
And I think I will advise our candidates to be taking not more than 5 minutes in answering the questions so that there will be reactions. The essence of this is to guide our candidates. If we allow them to take the whole time, we will be left with no time to react to their answers. So I will advise they shouldn't be taking more than 5 minutes out of the 10 minutes.
Okay, thank you, Dr. Jonathan. It's like the residents are not, we have to guide you because you are wasting so much time. What are the considerations? You need to know what they mean by consideration. What are the options for postoperative analgesia? Okay. The fact that the patient is having typhoid, we will also be on parenteral. We have parenteral. Okay. Then what you can do is to reduce the dose. So you can do multimodal, paracetamol, diclofenac. There's no contraindication to it. Okay. You can use opioids. There's no contraindication to it. Intraoperatively, you can use short-acting opioids like fentanyl. Okay. Then post-op, you can use morphine, but you have to know the age of the patient and even the clinical status of that patient. So infiltration is one of the options. Okay. You cannot be talking about epidural. Patient that is toxic. When will you insert your epidural?
Sorry, sir.
This type of perforation, most of the time, they look septic.
Yes, sir. But sir, the infiltration, sir, I have a question. The infiltration, I thought we do the infiltration in intra-op, sir. Because the question asks for post-operative anesthesia, sir.
If infiltration can be given post-op, infiltration can be given post-op. They may not use it intra-op. But when the surgeon are almost finishing, you give them the local anesthetic and you ask them to insert to infiltrate the wounds. Okay?
Yes, sir.
So, yes. Doctor, I think somebody is raising an issue on the opiates. Not for meeting, you give antiemetic because any emergency condition, you have to give acid prophylaxis. Okay. Are you not? I think our time is up, or
Yes, it's up.
Dr. Jonathan.
Yes, let's go to the next candidate.
Next candidate. Okay, I think that my partner can ask
Okay,
the
sir.
next question.
Yeah.
I think.
Okay, sir. Thank you, sir. Dr. Opusunju, I don't know if she's here. Dr. Opusunju. I think she's going
Dr.
for membership.
Opusunju is here. Good evening, ma'am. Good
Good
evening, ma'am.
evening. Yeah, good evening. Please, can you tell us about Bears block? Bears block, what is Bears block? B, complications of Bears block. And then C, describe in details how you perform Bears block for removal of a ganglion in the dorsum of the hand of a 32-year-old man. What is Bears block? B, complications of Bears block. Describe in details how you perform Bears block for removal of a ganglion in the dorsum of the hand of a 32-year-old man. Dr. Pusunju.
Yes, ma'am. Sorry, I was taking notes of the question. Good evening. Beers block can otherwise be called or referred to as intravenous regional anesthesia. It is done. It can be administered on the upper arm or the lower limb, just to manage pain during the surgical procedure. It is commonly used for procedures that do not extend more than 60 minutes. Complications of Beers block include local anesthetic systemic toxicity. There could also be allergic reactions to the local anesthetic agent. There could be vasospasms. There could be damage to neurovascular bundles around the vessel that is to be used. There could be ischemia of the distal digits. Okay, then how to perform Beers block? Before Beers block is performed, a detailed history has to be taken from the patient. One would want to know the procedure the patient is coming for, the pre-morbid state of the patient, if the patient has had surgery before, if there are known allergies. All those ones has to be sorted out. The patient has to be examined. Investigations has to be ordered. And the main thing is that consent has to be obtained before this block is being performed. We have to explain to the patient what Beers block is, why the patient is having Beers block, and tell the patient the complications and benefits of Beers block. By that, I mean the patient has to have an informed decision, has to make informed decision about this before and give consent. So the agents to be used, the materials and the machines have to be
Hello,
put
Dr. Opusunju.
Yes, sir.
The questions is direct. How do
Yes.
you perform? They are not saying you should. How do you perform? Those are the things.
Okay,
It's direct.
I'm coming there, sir. Okay, monitors will be attached to the patient in the theater. After monitors have been attached to the patient, like monitors like non-invasive blood pressure, pulse oximeter, ECG, those are key things that have to be performed. Emergency drugs have to be made available and drawn. Oxygen and means of administering oxygen have to be on ground. Then patients will be laid supine, and intravenous access will be instituted on one of the hands, while another one will be instituted on the other hand, where the block is going to be instituted. Then 2 tourniquet will be applied at the upper part of the arm. That's the arm, yes, not the forearm. Now, 2 tourniquet will be applied. The patient's blood pressure will be checked, and the tourniquet will be inflated to about 100 millimeter above the systolic blood pressure. After that has been done, the local anesthetic agents to be used, preferably lidocaine, will be drawn according to the patient's weight, looking at the maximum safe dose. And it will be administered. The 2 tourniquet will be inflated before this agent is administered through the IV line where the surgery is to be performed. On the other hand, an intravenous fluid is ongoing in case there's need for resuscitation. So after that has been, the medication has been injected into the hand, some time is allowed, about a minute or 2, and the proximal tourniquet will be maximally inflated, and the block assessed before the surgery commences. Even if the surgery the surgery ends before the span of 60 minutes, the tourniquet is not going to be deflated. Then at the end of surgery, tourniquet is going to be deflated bit by bit, so that much of the local anesthetic agent is not maximally sent into the cardiovascular system, which may be detrimental to the patient. Thank you, sir.
Well done, Dr. Kusunju. There were some mistakes. You said 60 minutes. It's for short procedures for 30 minutes, okay? And it can be used for both upper and lower limb. The question is detail on the Bears block. So it wasn't necessary, actually talking about history and all that. Then the cannula. Please, can you talk more on that cannula? You said 2 cannulas. What are the sizes?
Okay, the cannula is expected to be a wide bore cannula. For an adult, I would use a size 18. The least I can use is a size 20, which is the pink cannula. Yes, ma'am. Because it meant, the other hand is meant for resuscitation, while the one on the arm for surgery is meant for administration of the local anesthetic agent, ma'am.
Okay, so the one for resuscitation, what size will you use?
I said a wide bore cannula. I would go for a size
then
18.
The one for the block, what would you use?
I would use a size 20, ma.
Okay, no problem. Then the tourniquet, you said something. Which one is it? Are you inflating first? Is it the proximal or distal? When we're talking about proximal and distal, to where? Is it to the heart or the hand?
The one to be inflated first is the distal. The distal is the one closer to the fingers. Then the proximal, after some time, the proximal, when the patient starts feeling some pain around that area, the proximal cuff, that's the one closest to the shoulder. you'll be inflated, and
Okay.
you'll be maximally inflated, and the distal curve will now be gently deflated, ma.
Okay. So what local anesthetic agents is best for Bear's block?
I think lidocaine, ma.
Lidocaine.
Yes, ma.
Is that
Lidocaine
the
is better,
best?
ma.
Is
No, that's
lidocaine
not
the
the
best? That's not the best.
Prilocaine is better, but because of the side effects, we tend to avoid it.
Yes, the patient may have may be predisposed to methemoglobinemia, ma. That was why I went for lidocaine, ma.
Yeah, but ideally, Prilocaine is better. Okay.
Okay, ma. Thank you, ma.
Yeah, well done. Thank you.
Thank you, ma.
Please, one of our seniors is raising hands. Professor Sotoye, if I can see clearly, may we allow him to react to some of these answers?
Okay, thank you very much. I'm glad to be in the class, and I'm enjoying every bit of discussion this evening. Actually, I'm listening to you right from my remote village in the Niger Delta region. Good evening, all.
Good evening, sir.
Yeah, Opusunji tried in her attempt on the question, but I want to quickly add one thing that confused her. One, as soon as the intravenous access for the administration of the local anesthetic has been established, the limb will be raised up to drain as much blood as possible. Sometimes we use what we call S-match bandage to sanguinate the limb so that the blood volume there will not cause a dilutional effect to the local anesthetic agent. And immediately after that, a distal tourniquet is applied. A proximal tourniquet is applied. That is the tourniquet that is closer to the shoulder is applied, while the one closer to the forearm will be loose. The reason for that is that by the time tourniquet pain will begin to set in, you inflate the distal tourniquet, which is closer to the elbow, you inflate it, and then that area had already become anesthetized, and then the tourniquet pain is averted, while the proximal tourniquet is released. So this is very, very important. But overall, she really tried. Thank you very much. Good evening, Bode Lawal. Good evening. Thank you.
For the correction, sir.
All right. Thank you, sir. That was a very important observation on this answer she has given. Just before we get to the next question, I will also add that sometimes it's good to dilute some of these local anesthetic.
It's not here.
Sorry, is it possible to ask those that have indicated?
And the thing is, we don't know if they are part
to
one
raise
or
their
part two.
hands. So when we see them, then you
Yes, I think we can take, since we can take those who are raising their hands intermittently.
No, let those residents who have submitted their names to be part of this webinar that are around, let them raise their hands so that you can see them and call anyone. Maybe that will help.
Okay, sir.
Thank you.
Okay, so the question is, 86-year-old lady with subtrochanteric fracture of right femur present for total hip replacement. 86-year-old lady with subtrochanteric fracture of right femur present for total hip replacement. 1, discuss the pre-operative management. 2, list the techniques suitable for this procedure? What are the possible complications post-op? Is anyone that wants to attempt should?
What I mean is that all those who have sent in their names to be part of this, let their hands be up, all of them that are here.
Okay.
So it's easier to see them. Then we can call on anyone because this webinar is for them, and then there is a poor response, so they don't want to. So raise your hand. This is not the exam. It's better to make a mistake now. Thank you.
So for okay, Dr. Adeoye, yeah. Dr. Adeoye, can you attempt, please?
Yeah, she has answered before, so let somebody else.
Okay, another person.
Dr. Okusoji too has also answered the question.
She has also answered, yeah.
Let's see other.
Well, the one that attempts more will get the correction more, and then we'll have a better chance at the exam. That's it.
Yes, sir.
Hello?
So we shouldn't deny them if they want to attempt. Thank you.
Hello?
Okay.
Yes, Ekaete.
Dr. Yes, you can go on. Olukayode, are you? Dr. Olukayode. Sorry, we're not hearing very well. It's like
is there any electronic something open at your end, Dr. Olukayode of Madola? Please solve it.
Hello, sir. Hello, can you hear me?
We are hearing you.
Okay. Thank you, ma'am. This is anesthesia for the geriatric patient coming for total hip replacement. In preoperative management, this patient is elderly and who may have with reduced organ functions at this stage of life. And so you may come with comorbid conditions which one needs to evaluate and examine them subsequently, which could be like hypertension or diabetes. All this will be ruled out. Their drugs will be known and optimized before surgery. Investigations, then history also around end organ damage, whether they've had heart failure before, stroke, or any kidney injuries. Then they will be investigated along this line with an ECG, chest X-ray, to ECG to rule out silent myocardial infarction or any other heart-related condition which they may have, and EUC creatinine, electrolyte urea and creatinine to rule out, to determine the kidney function. Then the chest X-rays will be done. Is to see the size of the heart or any other respiratory problem which may coexist, like COPD in them. And the medications will be optimized to surgery after consent has been given, and they've been assessed, classified into the anesthesiologist group which they fit in before the surgery. Then they will be counseled on medications to take before surgery and those not to take based on what they are being treated for currently. And consent will be taken, then blood will be made provided, and the procedure explained to them, the choice of anesthesia which will be offered. This surgery is amenable to regional anesthesia technique, and so this will be offered to them. The second question says, discuss the option. I will discuss an option of combined spinal epidural with this patient and cancel. I also, sorry, pre-operatively, I want to examine the back since I want to, my choice is combined spinal epidural. This will be examined. This is an aseptic procedure which will be carried out, but preoperative, preemptive analgesia will be given to these patients so as to enhance better positioning for the procedure. This is before, from the ward, before as a means of pre-medication, and it will be non-steroidal anti-inflammatory drug or a weak opioid. So the second is I'm going for combined spinal epidural. So this is be done aseptically, in which the patient is well positioned in theater, and I'll make use of an assistant. I will drape, I will gown and clean and drape the patients, and at the point of insertion of the epidural, I want to do a needle through needle epidural technique, combined spinal epidural technique. After locating the spinal space between the L3 and T4 vertebrae, I'll use loss of resistance needle, loss of resistance syringe. I will use loss of resistance to here to determine the epidural space. Through after determining that the spinal will be instituted using the spinal needle through the epidural needle to locate the spinal space, and a low dose of because of the age, I want to use a lower dose of heavy marking for this procedure, and this will be 12.5 or 10 milligram of heavy marking will be used. Then the catheter will now be threaded through the epidural needle, and the space is secured and well fast plastered to the back of the patient. Then a test dose of the lidocaine with adrenaline will be start to be sure that this is not any vascular. Hello, am I being heard, sir?
Yes,
we're
yes,
hearing
you're
you,
being
but
heard.
you have
Continue,
exceeded
please.
The third question is,
I guess he's exceeding the time, so that
the postoperative
reactions.
complications of the procedure will be could be pain if not properly managed. Patient could develop thromboembolism. Patient could also have sorry, I've forgotten the other bone cement implantation syndrome, which will be avoided before which I will instruct the surgeon to inform me before applying the bone cement, which I will want to preload the give further fluid and be ready with my vasopressors before giving, and like to monitor the patients at shorter intervals. By the time this is administered, I'll keep checking the blood pressure like every 2 minutes, talking to the patient to know how the patient is feeling, since the patient is going to be conscious. So these are my little.
Okay, well done, doctor. It's a good attempt. But in your pre-operative, about the fact that the man is elderly, and your consideration, at least some specific ones should be bordered around the fact that he's elderly. And then still your consideration, at least the surgery, you said it later in the complication, the bone cement syndrome that usually occurs. Anesthesia, you said combined spinal epidural, and then you reduce the dose of the spinal. What is the advantage of using combined? Why do you want to use combined spinal epidural? What's the advantage of using the subarachnoid block?
Yes, the subarachnoid block takes effect faster than the epidural block. So this is to use in starting the surgery.
But the risk of hypotension, I'm sure you thought of it. That's why you said you want to use a lower dose. But in this,
yes, ma'am. Yes. Sorry, ma'am. I didn't get you.
We could just use epidural. He's 86 years old. Epidural,
yes,
the hemorrhage, so we can be safe and say epidural. We're not in a hurry. What I'm trying to say is, you said combined spinal subarachnoid block. I'm sure you're taking of hypotension to start this case.
Yes,
He's an 86-year-old man. The risk of hypotension is that he might have some comorbidities, which
yes.
want to yes. So it might just be safe to say that. And well, all in all, it's a good attempt, but you still need to go and read about it. And when you're talking about your pre-operative management, please let's try to arrange ourselves. You can use the patient surgery anesthesia considerations. That way you will say a lot of things, and you have to be specific. Don't be generic. Be specific to the particular question. Or you can use your, okay, it's pre-operative, so he's patient surgery anesthesia. Well done, doctor.
Thank you.
Well, I don't know if we have any reaction from our elders. Well, if there's none, then we can get to another candidate.
I think Dr. Edipo can ask the next question. Thank you, sir.
All right.
Thank you for the opportunity. It's like we have the same people. I don't know whether the other people, the other candidates are not here. I don't know. It's Dr. Opusuji is the only one I'm seeing his hand. Is there any other person? Is Dr. Aminu Awalu Bala around?
Adeoye also is raising hand.
Okay, he's also raising hand. Okay, maybe I should go to
Charles Mwogu. Charles Mwogu is raising hand.
Okay, Charles Mwogu will be the, okay. So, Dr. Charles Mwogu, your question. Call me. Okay, your question is a 75-year-old with long-standing hypertension and diabetes type 1 is scheduled for laminectomy and pedicle screw fixation. 1. What are the anesthetic consideration? 10 marks. B. Briefly describe how you would maintain optimal glycemic control perioperatively. C. List the possible suppurative complication. Dr. Charles. Dr. Charles.
Hello, sir.
Did you hear the question?
Yes.
Okay, you've written them down. First is that what are the anesthetic concentration? B, briefly describe how you will maintain optimal glycemic control perioperatively. And C,
time allotted to it. Is Mogu still with us? Hello, can we still hear ourselves?
Yes.
Yes, sir.
The question was directed to something. Any response from me? What's the problem? Okay, I think you can take a decision on that question. You can give it to another candidate if it's
Sir,
not
please, we couldn't
forthcoming.
hear you at some point.
Sorry?
We couldn't get the question, sir.
You didn't get the question. Hello, can the question be repeated to them? But the question, the summary is that is an elderly with hypertension and diabetic mellitus that is coming in for surgery. What are your anesthetic considerations? Is one. The other one is, how will you maintain an optimal glycemic control? Preoperatively. And as a third question to it.
You can go on, Wogu. You can go on.
Okay, I didn't get the question. The network was locked out.
A patient coming for laminectomy.
It says how old?
75-year-old man coming for laminectomy with long-standing hypertension and diabetes. Number one, the first question is, what are the anesthetic considerations? The second question, how will you maintain optimal glycemic control intra-op? And the third question is, list the perioperative complications.
Okay, thank you. The anesthetic considerations for an 75-year-old man coming for laminectomy include one, the 75-year-old is in the elderly age group with an attendant physiological changes associated with the elderly. The 75 years old have some comorbidities which will be sought out for after. In the question, the patient is a non-hypertensive, long-standing hypertensive and diabetic. Neuropathy and other conditions. So, quick after the physical examination, we want to do an investigation, a full blood count to check for maybe anemia. We want to also do an ECG, X-ray, to rule out any chest pathology. COPD is very common among the elderly. The chest X-ray will also look at the cardiac size to look at if the patient has a cardiomegaly, sorry. The ECG will also be able to look at any signs of ischemic heart disease. As a diabetic, the patient is put on silent myocardial infarction, so that will also look at. This will be cancelled for the fasting guideline to ensure that the patient does not have any solid food 6 hours prior to the surgery. Options will be discussed with the patient
a general anesthesia with muscle relaxation, because the positioning will also be put into consideration, because laminectomy that we done under prone position. All this will be discussed with the patients, and informed consent will be taken. Then this patient, as an elderly, I wouldn't want to do a pre-medication with benzodiazepines. And if I must do, I also have to reduce the doses. And knowing that it's a hypertensive, I will benefit from that. Inside intraoperative, there's considerations. Intraoperatively, in the theater, before patient comes to the theater, a quick check of machines and the resuscitation equipment will be done, and this patient will be brought to theater and vital signs checked. The induction of anesthesia will be done using intravenous propofol, 2 milligrams per kg. However, and for a non-diabetic, I will need to obtain the pressure response with intravenous lidocaine, 1.5 milligrams, about 30 minutes before laryngoscopy. And once this patient has been intubated,
Sorry, you said diabetic. Diabetic. Is it because of diabetic you are giving lidocaine?
You said hypertensive diabetic, sir.
But you didn't say, you said because the patient is diabetic, I will give.
No, I said it's a non-hypertensive, not diabetic, sir. The question said hypertensive diabetic.
I've heard you.
Hello, sir. Okay, another consideration is the positioning. This patient is going to be on prone position, and care must be taken to be able to position this patient. And I must say that we are going to use an armored tube, a non-kinkable tube, so that the tube does not kink while we position the patient. As a non-diabetic, the pressure points must be well padded to prevent neuropathy intraoperatively. The second part of the question, how will I ensure glycemic control intraoperatively? I'm going to use the GKI regimen, which I will use 10% dextrocyline with 10 international units of soluble insulin and 10 millimoles of potassium chloride. Depending on the intraoperative glucose of the patients, that's what I'll use to titrate to effect to be able to ensure that I maintain the glucose level to less than 11.1 millimoles per liter. The last part of the question, what is the intraoperative, the complications? I don't know whether it's intraoperative or postoperative complications of the last part of the question. The complications of the intraoperative complications of this patient is, one, the patient is prone to having a pressure source from a nerve injury from the prone position. It's a complication. Blood loss, hemorrhage is a complication in a patient built for laminectomy, which will also be managed intraoperatively, because the surgeons, during the laminectomy, the surgeons irrigate, and quantifying blood loss is actually difficult. So that we watch out for and manage actively. The other complications that can happen intraoperatively, nerve injury from the surgical manipulations around the spine, and can also be a complication. And that will also be checked in the immediate postoperative period. Thank you, sir.
All right. I think we've spent so much time on this, but it's worth it because we gave you time to educate us on the much you know on this. Otherwise, you really exceeded the time that's supposed to be allotted to this.
Thank you. I don't know whether I can talk because it's like there have been breakages in the connection. I've been having the thing being disconnected. I don't know whether it's the same at your end there. Time. So, however, Dr. Charles, this is a non-diabetic elderly patient and hypertensive You talked on some of the things, but you didn't talk about the challenges of autonomic neuropathy as part of your assessment. The patient will be on drug, what type of drug the patient is on, and how do you modify it, okay? Then you didn't talk about difficult intubation. This is a diabetic patient, 75-year-old, with spine problem, for spine surgery. You should also anticipate difficulty in intubation. Patient positioning you mentioned, but how do you protect the bony prominences and prevent injury? The kinking, can you hear me?
Yes, I can hear you, sir.
Can you hear me? Hello?
Yes, we can hear you.
We can hear you, sir.
Yes.
Yes,
The
we can.
patient is going to be prone. You didn't talk about kinking of the tube,
I did,
when
sir.
you should use armor tube. You did? Did you talk about armor tube?
Yes, sir.
That was the time the thing was breaking, okay? Then most of the time I didn't hear you except for the initial part, so I wouldn't know what you have said. Then the second part of the questions, I think second part of the question says, briefly describe how you will maintain optimal glycemic control. Did you discuss that?
Yes, sir.
So how do you want to do that? Because
Yes, I think.
Just briefly, you don't have to go to phase.
Yes, I said I'm going to, in the intraoperative period, to manage the glycemic, to have a glycemic control. I'm going to use the GKI regimen, the glucose insulin potassium regimen, where I'm going to use 10% dextrosaline with 10 international units of soluble insulin.
Is it dextrosaline? Is it dextrosaline that you use? Hello?
I know it's dextro, I don't know. Dextrose water, sir.
It's dextrose water. You have to have it separate. There will be two lines.
Yes.
Patient will have a line for rehydration, for the fluid therapy, the other one for glucose. But there are problems with using GKI. Did you mention it?
No, sir.
Because GKI is not a good system, in the sense that with time, the insulin tends to adhere to the wall of the bag, and then you'll be given less. Then you have to reconstitute you have to be checking the blood sugar, and you may need to reconstitute it. So the best thing will be what?
To use the sliding scale, sir.
So what are the possible postoperative complications?
The post-operative complications will include atelectasis for this elderly patient in the post-operative period may have though it's a surgery at the back, the atelectasis from atelectasis because of the functional residual capacity is close to their closing volume. The elderly is prone to atelectasis in the post-operative period. The other post-operative complication around the elderly is cognitive associated with elderly in the post-operative period following general anesthesia is one of the complications. Deep vein thrombosis is also a post-op, ensuring that the patient has a DVT prophylaxis using the low molecular weight heparin or do a compression stocking in the post-operative.
Yeah. Okay. Chest infection is also a complication because this is elderly patient. You have chest infection.
Yes.
Okay. If prolonged immobilization can also cause them to have chest infection. I think you try. Okay.
Thank you, sir.
Hello, sir. Can I say something, please, sir?
Go on, go on.
Okay, thank you very much for the opportunity. Thank you, the candidate that answered. The point I want to point out is the intubation. You rightly told us that the patient is going to be placed in prone position, but you didn't tell us how you are going to intubate this patient. Ideally, you should have a couch that you intubate this patient, then with the assistance of other people, you now take the patient from the couch and then you position the patient on the operating table. And while doing that, that's when you take care of those pressure points. I think I didn't get the question very well, whether it's a male or it's a female. But you need to protect the eyes, you need to protect all the pressure points, not only nerve injury that you are scared of, but you are also scared of other vital organs like the eyes, the genitals, and the breast, and all that. And also the positioning also help in a way that it will reduce bleeding. It will encourage venous return and reduce bleeding at the site of the operation. So I wanted to comment on that. The other thing I wanted to comment here is post-operative pain. You didn't mention it as a complication, but if pain is not well managed here, it's going to be very, very painful. So you need to talk about that as well. Thank you, sir.
Thank you, sir.
I think we can take one more question. Time is fast spent, I can tell you. We can take one more question and then take a summary of what we've done before we are timed out. Do we still have questions?
Yes, we have questions. Okay, a 60-year-old with prosthetic enlargement associated with back pain is scheduled for
There's something that will go away.
What is the perioperative considerations? Perioperative considerations. 2, discuss possible post-operative complications. A 60-year-old with prosthetic enlargement associated with back pain is scheduled for transurethral resection of prostate. 1, perioperative consideration. 2, discuss the possible post-operative complications. Can we get some hands up, please? Dr. Adeoye, your hand is up. Dr. Adeoye, good evening.
Operative complications. I was writing it down. Good evening, ma. This is my network.
Your network is breaking.
Hello, ma. Hello, ma. Can you hear me now?
You. Yes, I can hear you now.
Okay, ma. I stopped in perioperative complications. That is, I got only the first part, ma. Can I go ahead like that?
Yes, perioperative consideration. I discuss possible post-operative complications. Perioperative considerations, then discuss the possible post-operative complications. You can go on.
Okay. It's a 60. Good evening, ma. It's a 60-year-old man. Old man with prosthetic enlargement associated with pain, scheduled for transurethral resection of the prostate.
Yes.
Okay, ma. So this is it's a middle-aged man coming for transurethral resection of prostate. as an is an elective surgery because it's scheduled. It's an elective surgery. So care should be taken both intra-op and peri-op in the management of this patient. The complications that can arise perioperatively will include, who's calling me? Complications that can arise perioperatively will include from the surgery itself, from the patient and okay, from the surgery itself, this patient is coming for transvaginal incision prostate, and one of the complications that can arise is electrolyte derangement, especially sodium. They usually come intra-op. The surgeons insufflate the abdomen with glycine, and glycine can cause hyponatremia. So we have to take care of that as well. So we have to watch out so we can, to avoid that complication of hyponatremia. Then also he has prostatic enlargement. Prostatic, that is prostate. Okay. I don't think I started this question well because I just went straight to the perioperative.
You can rephrase. You can rephrase.
Okay.
Perioperative consideration. Perioperative.
Okay, consideration.
Yes, perioperative consideration. Yes.
Okay, ma. So
and you have to be fast to enable us to finish this question. We just have like 4 more minutes left to end this program.
Okay, we start from peri-op management. Ample history is taken. Rule out what who is calling me. Rule out other comorbidities, because in this age group, the patient may be asthmatic, hypertensive, or have other comorbidities. So there's ample time to rule out other comorbidities. Examine the patient properly, and you have to work up this patient for surgery. Do a full blood count to rule out anemia and other hemodynamic conditions. Also, you do electrolyte, urea, and creatinine, because it's a prostatic surgery, but it may have other electrolyte derangements. So you check EU creatinine to check the stability of his kidney, because the drugs we are going to use, some of them are excreted via the kidney. Then is 60-year-old, you do a chest X-ray to rule out any chest, any abnormality also. Then work him up for surgery. So among the consideration you're going to think of electrolyte derangement, that is hyponatremia. Think of pain post-op. Think of bleeding, hemorrhage. So you group and cross-match blood. Think of pain. So you optimal pain management should be given to this patient. Then the mode of anesthesia, we can do an epidural for this patient, or combined spinal epidural. I will personally go with combined spinal epidural because the epidural may take time to set. So combined spinal will give us times for the surgery to start on time. Then intra-op, we're going to monitor this patient's vital signs closely. I don't like the way people are disturbing me. We're going to monitor these vital signs closely, and look any abnormality intra-op should be treated. Then post-op, monitor the pain. Pain management should be optimal. As I said before intra-op, we are setting up epidural. So this epidural set can also serve as a pain management post-op. So we can give him a walking epidural to help him control his pain, or we can give him a patient control anesthesia. But I'll go with, since he has an epidural, you can just give him a walking epidural to take off his pain. Then I think that's all, ma. I was trying to rush.
No, sorry, I have problem. My thing, the system, I disconnecting and connecting. I was off. Like I'm on my handset now.
Dr. Joy.
No, the panelists can make their final comments before I take a summary, then hand over to.
Okay, well done, Dr. Joy. You started well, but I think you were distracted. Now, the question is 60-year-old with prosthetic enlargement associated with low back pain. With back pain.
Oh, I
you
didn't
said
get
nothing about the back pain.
I didn't get the
You
pain.
at least investigate.
Back pain.
No problem, no problem. At least you try to investigate that back pain, both for legal reasons and for care of this patient. You want to know if it's localized. You want to know where exactly, what vertebrae, because you said you will give combined spinal epidural. All right, so you have to talk more on that back pain. And then the fact that, okay, you said it's middle age, right? Okay, you said the investigations and all the intra-op. You said nothing about the intra-op considerations and the post-op.
And
then the fact that
hemorrhage, hyponatremia.
You have to try and organize yourself on that, okay? Then the post-op complication. Did you say anything about it? That's the full question. Post-op, discuss possible post-op complication. Did you say anything about it?
I thought you said consideration.
Possible post-op complication. I think basically they want you to talk about the TRP syndrome, which is common in patients that undergo TRP. Okay? Yes. And then your consideration should also consider how you manage this patient, monitor the patient, all the positioning of the fluid, 60, 70 cm, higher than the strat, avoid the vascular absorption, the kind of fluid they will use. All those are important. So try and read around TURP so that when you're faced with this question, you can go, you can go at least pre-operative, intraoperative, and post-operative. Well done, Dr. Day.
Thank you.
All right. I don't know if Dr. Yedepo has anything to add, anything to add before I take a summary. Hello.
Yeah. Hello. Sorry. Network here is very bad.
Okay, I'm just saying that we are coming to the end of this discussion. I want to take a summary and then hand over to the chairman and the secretary to conclude this program. We are coming to an end. We've already spent 1 hour, 47 minutes. We almost consumed the entire time. So I don't know if you have anything to say if I take a summary.
Before you take the summary, to wrap things up, you may want to allow Madam IPP Professor Nwaso, and then this will be followed by Professor Paponle, because they have been with us from the beginning.
Okay.
And I've seen Professor Abubakar Sadiq, the incoming chair, faculty national, if he's around, in that order, and then you can wrap up.
Okay.
If it's okay with you. Thank you. So, Professor Nwaso, please.
Okay, Prof. Good evening and welcome, Prof.
Okay, good evening. Good evening. I want to greet everybody. I stand on the existing protocol. Because of our time, I just want to go straight to appreciate the organizers, the moderator, the panelists, and the participants of this problem-based learning discussion. I think it's a very good teaching platform, and I think that it's laudable, and we should do more of it, because it will help a lot, especially since it is targeted at the potential candidates for the exams that are forthcoming. So having said that, I want to just note on a general note that the discussions so far have been very good, very cordial, and very, the atmosphere has been very conducive. I just noted one or two things, maybe because of network issues or people not hearing people very well. But sometimes, I'm just talking generally, but I think I noticed with one Dr. Nwagu, when you say something, sometimes you say it under stress and you may not realize what you've said, and it's pointed out to you. If you didn't realize that that was what you said, it is nice to say, oh, sorry about it, or I take that back, and then say the correct thing, rather than to sound like you are arguing with the colleague you are interfacing with. That way you have a better outcome. So refrain from arguing or like sounding like you are disagreeing outrightly with what the other person is saying. You can put it in a nice way. Oh, sorry about that, and then say exactly what you said. Then the other thing I noticed was also when the panelists are making comments, it is nice for the participants to listen first, rather than to interject and say, oh, I said this, oh, I said this, oh, I said this, oh, I've already mentioned it, oh, I said it before. It's possible, yes, you said it, but it's possible also the other person didn't hear you. So maybe let the person finish the comment or observation, then you can say, oh, sorry about that. Actually, I said this, and this, and then you make your record straight so that it doesn't look like you're having a to and fro with your examiner. Okay. Then the other thing I also noticed is when you don't understand the question, please, it's allowed for you to ask again. Can I hear the question again? Or please, can you repeat that again? Or, something to ask the examiner to repeat the question is better than to answer what you think you heard, because you may tend to make mistakes if you do it that way. Just like in the last discussion with Dr. Adeoye when she misunderstood the question. So to avoid that, when you're not clear, you can ask, please, can you repeat the question? Or something like that, if the opportunity presents itself. So by and large, I think that I want to salute the courage of the participants, because it's not easy to talk in a very open forum like this with so many people and the fear of making mistakes and all that. But I think it's better to make mistakes during the learning process than to make mistakes in the actual exam. So don't be worried. I think it's a learning process, and we learn more and more every day by repeating the correct thing each time. So that's just my own contribution. Once again, I salute everybody. Thanks. Over and out.
Thank you, ma'am.
I'm through. I've finished my comment.
Yes,
thank you.
I think Professor Pafonle, if he's there. Okay, yeah, please. If Professor Pafonle is still with us.
Pafonle, please, if you have any comments, any advice for us, will you please take the floor? Hello, Prof.
Hello.
Hello, can hear you, Prof.
Prof, maybe.
Did you call me?
Hello, Prof.
Which of the profs?
Professor Pafonle. We're saying if there's any contribution she has for us, that this is the time to do that.
I think she muted as this thing is mute.
Please, sir, that was Professor Legbe. I don't know how to speak.
Oh, Professor Fakwanle. Professor Fakwanle.
No, I mean Professor Legbe.
Allow Professor Legbe to speak, please.
Okay.
No. I thought it's not that I'm itching to talk. I was just waiting for Professor Bakwanle's comments before is she around?
Okay.
I mean, is she able
Good
to
evening,
join?
ma. Good evening, ma.
Good evening.
Thank you so much.
Yeah.
Thank you so much for that honor. I am president of NSA and all the members of the committee putting this together. Yeah, Dr. Idepo, well done. I think I followed the trend of the discussions, and I like the initiative. Yes, this helps us. This helps us as candidates presenting for exams to know what to say. A lot of times, if you've done this over and over, different fora, you will find out that when you get to the exams, your confidence is there. Not that you're overconfident, and at the same time, you're not timid. You have your knowledge. And I like the way that the moderators and the panelists are guiding people's responses to the various case scenarios that are listed. It's a teaching way. It enables, this is for candidates and anesthetists generally, to understand the way we think as anesthetists. The way we think determines the way we practice. And there's a uniformity about it. It's all over the world. History taking, physical examination, investigations. There is something about us that makes us peculiar. And this enables one to be guided along those things. I always tell people that anesthesia is not just about sleeping. There is something about different surgical specialties, about how you provide anesthesia for different surgical specialties. I mean, for pediatric anesthesia, for ENT, for general anesthesia, there are principles about it. And these sort of case discussions will help to train us. I was enjoying it and just nodding my head as the moderators were commenting and trying to correct. Thank you for a very nice, well done.
Thank you, Prof.
I think Professor Elebe is around too, and is ready to say something.
Okay.
Yes, thank you.
Professor Elebe, please, may you give us your own contributions, if you have any.
Professor Elebe, you have the floor, or maybe her network is gone off a bit.
Maybe network.
Yeah. Sorry, we'll soon round up. Okay, you carry on. If she comes before we give a final closing remark, we'll allow her to say something. Go ahead.
All right. Yeah. All right, thank you, Prof. At this point, I want to tell us that there have been a very beautiful participation. On the whole, we had 6 questions or 6 cases that we are analyzed and attempted answers given for them. If going through them, the first thing was TOF, tracheoesophageal fistula. I think the residents have been told to go and read around it, that some of the answers they gave were not so satisfactory. On the issue of pre-operative considerations for an elderly hypertensive patient with peritonitis, there was, a misunderstanding of how to understanding the question that was asked. The pre-operative consideration, somebody was giving us the answer as management. There are two different, if you ask about management, you ask management. If you say pre-operative considerations, they are different. And I know that our facilitators tried to bring the residents to order. BS block was the third case we had, and it's very important. Residents should also read around BS block, very important. Certain lights have been thrown on that to guide residents on how best to do BS block. It's not just about reading about it. You should go close to your seniors to know how it is being performed. The fourth case we had was total hip replacement. We also advised to read around total hip replacements. The attempt at the answer by the resident was okay, but it wasn't so satisfactory. The elderly with hypertension and DM. This has been a recurrent question in exams. And I tell you why it recurs is that if you come to the hospital, most of the patients will come across, most of them have either hypertension or diabetes. So any resident going for exam should at least know how to manage hypertension and diabetes. I don't think it's something a resident will just overlook and say, go for exam and come back. You should go close to your seniors and find out how the management of these cases are being done. And then you prepare for exams so that you supply the answers at the tip of your fingers when you are asked. Now, why discussing prone positioning? The resident who attempted this question didn't mention anything about Montreal mattress. It's important. Even if you don't know what it is, please go and find out what Montreal mattress means, because you can't put any patient on a prone position without a Montreal mattress. The final question we had was top transrectal resection of the prostate. It's also important for our residents to read around it. Is one of the innovations that is gaining ground today all over the world, and I think we should know the preoperative considerations and the complications that can arise from it. Finally, before I hand over to the chairman, I want to use this opportunity to appreciate our teachers, our professors, and our senior colleagues for bringing out this time to always come around and continue to carry us like babies and sucking breasts. I really appreciate. At this point, I will be handing over to the chairman. And before then, just to remind you who I am Dr. Jonathan Chukwemeka Eya, former head of departments and former head of ICU in Enugu State University of Science and Technology Teaching Hospital, Park Lane, Enugu. Thank you, Chairman.
Thank you very much, Dr. Jonathan Eya, for this wonderful moderation. I made some notes here. Before I conclude, I can see Professor Leve. If she's okay, she can say something before we conclude.
Yeah, thank you very much, Dr. Dati.
Yes, ma'am.
My hard disk failed me because this is the first session you're having, and I have been jealously guarding it that I don't miss the time. Unfortunately, I was in the same soup again. I got to remember very late. Now, I quite appreciate the comments of Dr. Nwazo. Very, very appropriate and right. And I think you should all take note of it. The questions are very typical questions, and they are questions that you come across every day of your life, very common. When they ask you common things and you fail on it, they are never impressed. Examiners are never impressed on the rare ones, even if you make excellent, because you may never come across it in your life, or it might take you a time to come across it. But the ones that you see on a regular basis, hypertension, diabetes, hip replacement, knee replacement, all that stuff, even simple tonsillectomy, adenotonsillectomy. If you don't do it well on things you are supposed to see every day and practice everyday anesthesia, examiners will be very happy to fail you. So please take note and always remember that the examiners are not looking for some special things that you read in your book. They are not looking for textbook stuff. They are looking for your practice. How did he manage? How can he manage this case? So always have that in mind and always relate from your practice, from what you do. They are not looking for something special, please, okay? And to the moderator, you said the answer was okay, but not satisfactory. When something is okay, it means it's satisfactory. So I don't agree with that, your comment. Okay. If it is not satisfactory, then it is not okay. And it's important at least to, as examiners or senior people, try and take note of some of those things that does not make the answer okay. And then we can point it out to them or to the candidate at the end of the question. Well done. I am really happy about this, and I just wished I started with you all from the beginning, but I'm sure there is still room for me for the next one that you do. Well done, everybody. Dr. Dati.
Thank you, ma'am.
I love my heart.
Thank you. Thank you so much. It's all noted. I will allow. Okay, we have two more coming on 30th and also on the 7th of October. I think I've noted that perhaps next time we will open, we will share a screen PowerPoint, and then as the question is being rolled out, we will just type it out so that it remains on the screen there. Maybe the residents respond better. That is what I plan to do next time. And then I want to ask I've noted senior colleagues here, trainers here, Osaheni, Rotimi, Bodelawal, and then at some point, Professor Sadiq was there for a long time, and so on. So please indicate your interest to be part of the next webinar, next Saturday. Please train us so that we have 4 or 5 of the facilitators. I think that will enrich the discussion. So just send private message to us, any of the ESCO member, and then we'll take note and we'll put you, we'll contact you for details. At this point, if the Dr. Oshele is around, just 1 minute, you want to say something, our PRO, and then we conclude. Dr. Oshele, please.
Good evening, everyone. Good evening, our trainers, our professors, and our teachers, the participants, the panelists. Thank you very much for being part of this webinar today. We just want to remind us that we should kindly please pay up our dues for NSA dues this year, and that our conference, NSA conference, is coming up in Gombe in this November, 27th of November to 1st of December. And if you have not registered, kindly register for the conference. And the early bird registration closes by 31st of October. Please kindly register to participate. And there is a list on the NSA page for those who are interested in going to Singapore. That is the World Congress of Anesthesiologists that is holding in Singapore next year. Please kindly add your name to it if you are interested in going. Thank you.
Thank you very much, and thank you everyone.
Can I make a comment to the PRO, please?
Yes, go ahead, ma'am.
Can he please give us a rough idea of the cost of going to that conference, so that people would either begin to prepare or start getting loan or something if they want to go? It's good to have an idea, and I'm sure you can do that. Find out roughly for us the cost of hotel.
Okay, ma, I will do that. Just that the cost of the fluctuation in dollars,
just a rough,
it's roughly about 1 to 1.2 million naira. But I'll find out and get the.
It's definitely going to be more than that. I can tell you
because
that.
of
all right.
Yes.
So
yes.
Give us roughly accommodation, a range from this to this, flight this, economic class, and what else? Registration.
Thank you, ma'am.
Just a rough idea. Instead
Noted,
of telling us to register and then we register and then we find that we don't have enough money to go.
Thank you, Prof. Yes,
all right, dear. Good night, everyone.
Hello.
Yes, we'll do. Yes.
Hello.
Yeah.
Hello.
Yes.
A quick comment
Good night, ma'am.
to follow up on that. I've checked the website. There are two aspects to registration: virtual or physical. Virtual is $100. Physical is $450 for low, middle income countries. So if you register, you will also now think of what your hotel bills are likely to be about $60, $100 maybe per night, depending on how long. Then they are working on trying to get rebates from airlines. So that has not been stopped, but you can register now. Registration will close by October 15. So either virtual or physical, $100, $450. You can start thinking of that and start trying to save the money. If you have registered, you can then start to put aside some money until the time towards your flights, towards your accommodation. Thank you.
Thank you very much. I think we will get all this information within a week, and then we'll keep updating it to guide interested participants at the Congress. Thank you very much, everybody. We'll look out for more information on this, the next webinar on Saturday. Thank you, and good evening.
Thank you, sir. Good evening, sir.
Thank you, everyone.